All right, we will go ahead and get started. Welcome, everyone. We are really excited to have everyone here on our first day of our 2021 Bleeding Disorders Conference. Before we begin into our topic of tonight, we have to truly thank our 2021 sponsors, our platinum, gold, and silver sponsors who are listed here. We really could not have done this amazing conference bringing our community together without the support of all of these community partners. So we really thank you. Next slide, please. So here we are to come together and talk about COVID-19. This is COVID-19, what's now, what's next. I will say, as we were planning this conference, there were a few moments where we're like, are we gonna have as much to talk about for COVID-19 by August? And clearly there is still a lot on all of our minds. So we are really happy to have a really wonderful panel together here for you to be able to talk about it tonight. Next slide, please. My name is Kate Namaker. I am the Vice President of Education at NHF, and I'm just going to be helping guide for how to make sure that you're getting the most of this session tonight before I hand off to all of our speakers and panelists. So a few of the tech features for the evening. You'll see a Q&A button at the bottom of your Zoom screen, and you'll be able to write in any questions you have there as you go throughout the session. And then at the very end, we'll have a really good chunk of time to make sure we can get to as many questions as possible. There will also be some interactive polling in Zoom for this session, so it'll automatically pop up on your screen. This is optional. We'd love to hear from the community and be able to interact a little bit during this session. So it is completely optional and anonymous, but we invite you to join us. This session also has written translation into Spanish. So at the bottom of your screen, again, on that navigation bar you have in Zoom, there should be a little CC button that says live transcript. And in that, if you click on that, you'll be able to see the Spanish translation. And Dawn just put into our chat another way. If you're having issues with that, you can always click the link that is put into the chat and be able to see a written transcription of this English session. As always, we would love to have your feedback. So tomorrow morning, you will get an email with all of the list of evaluation links to all of today's sessions. And we really encourage you to give us any thoughts or feedback so we can plan for a better meeting next year. And this is one of the sessions that will be recorded. So it'll be available sometime tomorrow, about 24 hours later on the conference platform. And with that, we will start our first poll. So we would just love to see who's here joining us tonight to have this conversation about COVID-19. Are you a patient, caregiver? Are you a chapter staff member, hematologist? Are you industry nurse, social worker? I got to scroll down. We have a lot of different types of community members here, physical therapist, or one of the other many different types of community members. So please join us in this first poll. It looks like we have a really good mix of patients and family members, as well as chapter staff and healthcare providers and industry partners. So, and I'm so curious about what the other is, but we don't know that tonight, but I think it's a really nice mix for our community here tonight. Wonderful. And those are the results. And with that, I am going to hand this over to Len Valentino, our President and CEO at NHF, to take it away. Thank you all for being here.
Thank you, Kate. On behalf of the National Hemophilia Foundation, I'd like to thank you all again for participating in this year's virtual Bleeding Disorders Conference. I hope that next year we'll be able to do this in person. So I'd like to introduce our fine group of speakers and panelists for this evening. First, I'd like to introduce Dr. Caitlin Jetlina, who is an epidemiologist and assistant professor in the Department of Epidemiology, Human Genetics, and Environmental Sciences at the University of Texas Health Sciences Center at Houston. Her research lab focuses on improving health access and outcomes for vulnerable populations exposed to violence, like victims of domestic violence and child abuse. Our second speaker is Dr. Scott Katz, a clinical professor of medicine at Wayne State University and a hospitalist at Henry Ford Hospital in Detroit, where he serves as the medical director for the professional development and research in the Division of Hospital Medicine. So I'd like you all to welcome Dr. Jetlina and Dr. Katz. But before we go to our first presentation, I'd like to ask the second polling question of all of us. And the question is really simple. Have you had COVID-19? Yes or no? We'll give people a chance to answer that. And we can see that there's a small number who have had COVID-19, but the vast majority have not. So I think that'll give us a good starting point for our presentations. And now I'd like to turn it over to Dr. Jetlina for her presentation. Thank you, Caitlin.
Hi, good evening, and thank you for having me. I am Caitlin Jetlina. I am an epidemiologist who has been thrown into this pandemic, this all hands on deck response, both as an epidemiologist in the field, but also as a health communicator. I am the founder and sole author of a viral blog called Your Local Epidemiologist, which translates the science to everyday, for everyday decision making. And next slide. And so I was asked to give a current state of epidemiological affairs, where we are right now. And I will say, we're in a scary place if my graphs from yesterday are a little out of date. So this data is from yesterday, though. We are clearly in our fourth wave of this pandemic, and we have clearly surpassed the first and second waves in the United States. Interestingly, we have very uneven spread in the United States. You can see at the bottom graph, most cases are, and transmission is in the South right now, Florida, Mississippi, Louisiana. Over the weekend, we had one new hotspot pop up in 2 different states, Oregon and Washington, the Northwest. We are keeping very close eye on, as well as Wyoming and South Dakota. Today, South Dakota's cases increased 500%. And so this seems to be spreading very rampantly in the United States. Next slide. This is just a graph to show you, this is cases among our 3 leading states right now, Mississippi, Florida, and Alabama. And all 3 of these states have even surpassed their 3rd wave back in winter. And so this is a very dire impact we're seeing in the South. Next slide. And unfortunately, after cases rise, we see a rise in hospitalizations and deaths. It lags about 3 to 4 weeks. And so this is the current situation in Florida. We have hospitalizations at the top, which have exceeded other waves of hospitalizations. And then also, unfortunately, at the bottom, the deaths, the number of deaths in Florida has surpassed the other waves as well. Unfortunately, this is because not enough people are vaccinated in the South and in Florida. The high vaccination states, and I'll show you this in a slide later on, have very low rates of hospitalizations and death compared to the states with low vaccination rates. Next slide. And so why is this happening? Well, our virus is mutating, and unfortunately, it's mutating about every 2 weeks in the globe. And the latest variant was Delta. It was first identified in India in December 2020, and then really took charge in the United States, at least in the early June. By the end of July, 80% of our cases in the United States were Delta. And then today it's close to about 95, 96% of our cases are Delta. This is why the World Health Organization called it the fastest and fittest variant we have seen. And we're not just seeing a rise in the United States, we're seeing a rise globally in the UK and Israel right now, to be specific. Next slide. And so Delta changes the game, right? So why does Delta change the game? One, it's 200% more transmissible. So what does this mean in English? It means it's more contagious, and it's even more contagious than the previous variant, as well as more contagious than the flu or smallpox or polio or Ebola. And it's as contagious as chickenpox. It has an R naught of about 8, which means one infected person on average will infect 8 other people. Thankfully, it is not as contagious as measles. Next slide. Delta also changes the game because of its viral load. It has 1,000 times the viral load than other variants. So what does this mean? It means we test more positive more quickly, and it means people are shedding a ton more virus. So if you come in contact with a positive case, the probability of getting infected increases. The other thing that Delta changes is a longer duration of shedding, a longer duration in which you're contagious. Before, you're about contagious 13 days on average. With Delta, you're contagious about 18 days on average. So what this means is that you just have more opportunity to infect others. Next slide. The other thing that Delta changes, unfortunately, means that the vaccinated can transmit the virus. Vaccinated, before Delta, the vaccines reduced transmission by about 90%. Unfortunately, with the Delta variant, vaccinated has the same viral load as the unvaccinated. Data just came out yesterday, actually, showing that unfortunately, the vaccines only reduced transmission by about 20%. Importantly, though, if you're vaccinated and you're a breakthrough case, it looks like after about 3 to 6 days, your vaccine kicks in and the amount of virus you shed significantly decreases compared to the unvaccinated cases. And so you're contagious for less longer than unvaccinated cases, which will sure help end the pandemic. Next slide. So what do we do? What do we do? One, we all have to wear masks indoors, whether you're vaccinated or not vaccinated. Masks not only provide inward protection for yourselves, the mask wearer, but also protects those around the mask wearer. A lot of questions I always get is what masks work? We know that what matters is your fit and your filter. So #1 mask is N95s. You can order those anywhere now, and we're not in a shortage of N95s. So the healthcare workers have plenty of them. The next is double masks, cloth over surgical. There's an 83% reduction in exposure when we have double cloths. The next is a knotted surgical mask. You can see the picture labeled C. And when you do that, there's about 65% reduction in exposure. And then the least useful or least effective is the cloth masks with a protection around 40%, but certainly much better than nothing. Next slide. What else do we do? It's time to be a lot more conservative with activities. This is an activity chart I created for parents on my blog, but it shows, what were low risk activities like, bike riding, being at the playground, what were medium risk, like traveling or outdoor activities like the pool, and what was high risk, like, for example, trampoline parks, indoor trampoline parks. And before the Delta variant, everyone, was on their own risk tolerance level. But what I tell everyone now that if you were in the red, you now need to be in the yellow. If you're doing yellow activities, it's time to switch to only green activities. It's time to be more conservative and more careful with your activities. Next slide. The other thing we need to do is we need to get vaccinated and get vaccinated fast. Vaccines work. They continue to work against hospitalization and death. Out of 168 million vaccines, we've only had 9,700 breakthrough infections that resulted in hospitalization and death. Our vaccines are fantastic, but they are not perfect, specifically for immunocompromised and those 65 and older. And we know the vaccine and those in the hospitals, like that graph I showed in Florida, are majority, vast majority among the unvaccinated. Among hospitalizations, unvaccinated account for about 95 to 99% of those in the hospitals. So we need to get vaccinated to keep you out of the hospital. Next slide. And this is a great graph I liked. The x-axis or the horizontal axis shows the percent vaccinated in a state. And then the y-axis or the vertical axis is the percent or the people hospitalized in that state. And what you can see is a downward trend. So the states with the least vaccination rate have the highest hospitalization rates, and the states with the most vaccination rates have the least least hospitalization rates. And so we know our vaccines work, especially in the light of Delta. Next slide. The thing we're not very convinced about right now is that our vaccines work okay against mild and moderate disease. We know that vaccine effectiveness against infection overall is slightly decreasing over time. For example, back in May, our vaccines were about 92% efficacious, and now they're about 78% efficacious, which means we will have more breakthrough cases, but those breakthrough cases will be more mild or moderate. Next slide. And this is why booster shots have been recommended to start in September 20th in the United States. And boosters are very common for other vaccines, right? In order to enter kindergarten, you need 5 DTaP shots. You need 4 polio, you need 2 MMR. HPV needs a booster. Adults need tetanus boosters after 10 years. If you could click one more time, please. So why do we need a booster shot for COVID-19? Well, our 2 doses were too close together in the beginning, and we did this strategically. Back in December, we were losing about 3,000 people a day to COVID. And so we gave them the full protection, the 2 doses, only about 3 to 4 weeks apart, knowing that it could be sacrificed, the protection could be sacrificed. Booster shots are most effective if they're at least 6 months apart. And so this is why we are engaging our booster shot this fall in the United States. Next slide. And so right now, immunocompromised are already authorized to get the shot. That includes organ transplant patients, cancer patients, HIV, active HIV or uncontrolled HIV infections. The general population is coming September 20th, which means you can get a booster shot if you have 8 months after your second mRNA dose, if you're 18 years or older. They probably not going to allow mixing. So if you got Moderna before, you're going to stick to Moderna for the 3rd dose. Unfortunately, we do not have data yet for Johnson & Johnson, but I know that it is coming and we expect it in the next few weeks. And likely Johnson & Johnson people will require a booster shot starting September as well. Next slide. And so as you probably know, this is an incredibly rapidly evolving environment. Back in May, vaccines were high, our rates were low. Maybe we thought COVID was going to be done. If we got vaccinated, we'd go back to normal. Then August hit, right? Vaccinated can still get COVID, rarely, but they do. They can spread it. We need masks back on, and our rates are increasing. Like I said, areas are even worse than were last winter. And so where are we going in fall? We're going to need booster shots, and we're hoping we peak in September, October. Epidemiologists are also a little worried about the winter months of January. I'm hopeful that if we get enough people vaccinated, we'll be back to quote unquote normal in April 2022. Next slide. So because of this rapidly evolving environment, how do you keep up? I always tell people stick to, 5 sources and boring, right? We need boring. And so you can go to NPR, you can do New York Times. If something comes up, I guarantee you one of those 2 will tell you if there's something you need to know. Like I said, I have a blog, 300,000 followers that's reached about 80 million people called Your Local Epidemiologist. And you can follow, I usually do one post a day about the new science coming out and how to make evidence-based decisions for yourself. Next slide. And that's all I have. This is my email address if you ever have any questions. And I think we're going to keep questions to the end and the next presenter is up. Thank you.
So we can ask Dr. Katz to take over now, Scott.
Well, thanks so much, and thanks, Caitlin, for setting the stage. I'm Scott Katz. I'm a hospitalist at Henry Ford in Detroit. Could I have the next slide, please? Here are my potential conflicts of interest. I've done a lot of research with anticoagulants, and what's sort of germane to this that's not on here. We have participated in 2 National Institute of Health studies right now with anticoagulants and COVID. Next slide, please. So I'm going to go through 3 concepts. Now, I know a lot of the folks on this webinar tonight are not medical professionals, so I'm going to couch this for both the medical and non-medical professionals, do my best to explain this. I'm going to get a little technical for the physicians that are on the call, and lots of hematologists also, although they deal with bleeding disorders, which is the nature of this conference, they also will deal with clotting disorders, and that's what I do. I am not a hematologist, however. I'm going to talk about this thing about microthrombosis with COVID. Then I'm going to present you a case, and then I'm going to talk about how we prevent this clotting complications with COVID in the hospital. Next slide, please. So, to set this stage, what happens is this is sort of a pictorial of a lung, and up on top is you have sort of on the very top you have the air sac called the alveoli, and then on the bottom of the top panel you have the blood vessel and the blood cells. The blood cells are the red things that look like a target, and that's normal. If we go to the bottom, when we have a COVID infection, the big yellow part that you see is edema, fluid. No different than if you burned yourself and you got a little water blister. Those things happen with inflammation, and that happens inside the lung. So it's harder for the oxygen to get through the air sac and dissolve into the bloodstream. And then what we have at the bottom is that we have a lot of changes that happen actually in the blood vessel. And one of those is a small clot. Now, we have known with COVID that patients can get the big clots, what we call a deep vein thrombosis, DVT in the leg, that can sometimes break off, go to the lungs. That's called a pulmonary embolism. But this is a different mechanism. This is clotting that's happening in the very, very tiny blood vessels called the capillaries. Next slide, please. So, an autopsy of 7 patients early in the pandemic, published in May of 2020. On the left is these small blood vessels, this net of blood vessels called the capillaries, and they surround the tiny little air sacs in the lungs, the alveoli, and that allows oxygen to get from the lungs into the bloodstream. You don't have to be a physician, a healthcare worker, or work in microbiology to tell that on the right, which is looking at the blood vessels of patients with COVID, that it's really damaged quite a bit. So the COVID virus actually inflames and injures the blood vessels. Next slide, please. And then on the right in panel D is sort of a computer rendering of a normal looking blood vessel, the tiny ones in red. In blue is the airways, the small bronchial tubes. And at the very bottom over on the left part of that panel is a little cluster, and those are the air sacs. On the left side panel C, you can see that not only are the blue, the airway is torn up from COVID. We kind of know that because COVID causes a pneumonia, but you can also see the damage that is done to the blood vessel. And so the thought is, can we do something to prevent the clotting and the destruction and damage that happens inside the blood vessel to allow more blood to get into the lungs so it can get more oxygen? Because patients with COVID primarily die because they can't get enough oxygen. Next slide, please. So here is for the clinicians, and if you're a lay person, you can play around along and guess also. But this is a 62-year-old patient that's admitted to the hospital with COVID, requiring at that time about 3 liters of oxygen. The chest x-ray is typical for COVID, normal kidney and liver function, and the D-dimer is elevated. In fact, this case is me. I contracted COVID in the spring, very early in the first wave. I was taking care of patients on a COVID floor for a couple of weeks when I contracted COVID. And the really question for the clinicians is, should we use usual lower doses of an anticoagulant, medium doses, or high doses? And I don't think that we have to do the polling here. I think I'll just talk about, but this is the question that comes up. So, and what happened to me at the time made sense, but now we know with data that I'm going to show you that I was treated completely incorrectly. Next slide, please. So here is a very important trial. This trial was just published August 4th online, and it appears in tomorrow's New England Journal of Medicine. This is the multi-platform randomized clinical trials. 3 trials combined: the ATTACK, the Active-4A, which is a National Institute of Health sponsored trial, and the REMAP-CAP trial. Active was primarily run out of Canada, Active-4A out of the United States, and REMAP-CAP out of the UK. The question is, should high dose therapeutic anticoagulation, is it better than our usual primarily low dose blood thinner that we give to almost all patients when they're hospitalized and ill? It's a randomized trial. There are 2,200 patients from 129 sites throughout the world in 9 different countries. We participated in that trial. I helped lead the trial at my institution. And it was done relatively early in the pandemic, from April of 2020 until late January of 2021. And the intervention was primarily low molecular weight heparin, a type of blood thinner, at the high, what we call therapeutic dose. And the comparison was to the usual dose, and primarily about 71% at that time, it was the lower, or what we call a prophylactic dose of similar medication. Next slide, please. So what we found, and I have circled in red in the middle column up near the top, is there was a 4% reduction in patients surviving until hospital discharge that also did not need escalation of care, did not need to move from the floor to ICU level of care. This is very important. This means for every 25 patients that we treat this way versus the usual way, we will have 1 less patient needing to go to the ICU. That is good, because we've all heard about the ICU shortages, and having spent 19 days in the intensive care unit when I was sick with COVID, being able to prevent getting that sick would have been a really good thing, but we didn't have this data at that time. Again, it's in tomorrow's New England Journal. Also, there is a marker, a blood test that we can do to try to see how sick or how much clotting might be going on, or what the risk of clotting is. It's called a D-dimer. And here, the D-dimer level, whether it was high or whether it was low, really didn't matter. We're pretty sure that this works for both groups of patients. Next slide, please. So Bleeding was a little bit increased, about 1 total percent, 1.9 versus 0.9 in the two groups respectively, but it wasn't overwhelming. Next slide, please. So an accompanied trial was also done. That same group looked at patients that were critically ill, that needed ICU level of care. And here, we did not see an improvement with therapeutic dose, the high dose of blood thinner. And the thought with that is maybe by the time the patient gets to the intensive care unit, the horse is already out of the barn. There's too much damage and a blood thinner can no longer help. And that is discussed in the editorial in tomorrow's New England. A different trial called the Inspiration trial, and this was published in April of this year, so a couple of months ago now, was in all ICU patients, 560 patients in the intensive care unit. The thought was, well, let's try a different dose. Let's try an in-between dose, an intermediate, medium dose of blood thinner, because we know that high doses of blood thinner might cause too much bleeding. And I know I'm talking to a group that either has a bleeding disorder or is a family member that's a bleeding disorder or takes care of bleeding disorders. So very reasonable and very important trial. And this is what happened with me. Once I moved to the intensive care unit, the thought was sicker patients need higher doses. And so we moved up to a higher dose of blood thinners when I was being taken care of. They compared a very common blood thinner called a low molecular weight heparin given at a intermediate dose. For the clinicians in the audience, that was 1 milligram per kilogram once a day. Remember, usual doses twice a day. So an intermediate dose versus a usual prophylactic dose of enoxaparin 40 milligrams once a day. And the composite was not only big clots in the veins, what we call venous thromboembolic disease, but also arterial thrombosis, things that cause heart attacks and strokes. And then if you got desperately sick and you needed dramatic measures with a bypass type of machine called ECMO, and then patients dying. They followed the patient for a month. Next slide, please. We don't have to go into the statistics of the primary outcome that is highlighted a little in the top. You see a 45.7 and a 44.1. Those are the same, so there's no difference. So the intermediate dose was no better than the usual standard, what we call prophylactic or low dose. And major bleeding was increased a little bit with higher doses of blood thinner, no surprise, 2.5 versus 1.4%. So what I received, and this is not criticism to my physicians, they clearly saved my life, but we didn't know at the time, and that's why we do science and randomized clinical trials, and it showed that we shouldn't use that dose. Next slide, please. So let's switch gears a little bit. And let's talk about the last topic, which is vaccine-induced immune thrombotic thrombocytopenia. Now, many of you in the audience and watching tonight know that low platelet count is a cause for a bleeding disorder. And so what is happening here is that the vaccines are related to a very unusual type of disease that even though the platelet count goes down, which would make you think that the patient would bleed, the patients actually get clots. They are typically getting clots in unusual places, down in the abdomen, up in the veins around the brain. And so this has been described, and probably these data are out of date because as soon as you make a slide, the data is out of date, it seems like with COVID. But you can get an idea of the rates. And if you look at the very bottom of this slide, and this is a slide that comes from the American Society of Hematology, it is very, very rare. With the Oxford AstraZeneca vaccine, which is primarily used in the United Kingdom, not available here in the United States, 9.4 per million patients. patients. And with the Janssen J&J, which is a similar family of vaccines as the Oxford vaccine, an estimate of 3.2 patients per million. So very, very rare. So this is really not a reason not to receive one of these vaccines. Next slide, please. And so the last thing is, if a patient is leaving the hospital, because we know that they have COVID, so they're at risk of getting a clot, should we give them a blood thinner as they leave the hospital? And we are participating in what's called the Active 4C trial, sponsored by the National Institute of Health, to try to answer that question. And a very, very special thanks to the patients that have agreed to help develop that science. We've already put in a couple of patients into that trial at our center. And Len, I'll stop there and turn it over to you.
Thanks, Dr. Katz. So we now have 2 more polling questions that we'd like to ask the audience to respond to. And let's pull up the first one, which is, have one or more of your family members had COVID-19 infection? So the responses are yes or no. Let's see what our group has there in terms of family members and developing COVID-19. You can see it's actually split. About half have had family members that have been impacted by COVID-19. And our fourth question is, have you received a vaccine for COVID-19? And the responses here are yes, no, I don't plan to, no, I plan to get one soon, or no, I may consider getting one in the near future. So 4 responses possible: yes, no, I'm not going to get one, no, I plan to get one soon, and no, I may consider getting one in the future. So we can see here that the majority of people have gotten a vaccine, so thank you very much. And for those that haven't gotten a vaccine, I hope that you'll soon be getting one. And I'm happy to see that the response there about no, but I may consider getting one in the future. So that's great. So we can now go to our Q&A session. So we'll bring up our speakers and allow questions. So I'm going to take the chair's prerogative and ask the first question. And that is, and I'll ask Dr. Jadalina, is there any new data on whether masking makes a difference? Where do you think we are with masks, especially with young children?
Yes, so masks do make a difference. In schools, there was a study that came out this week that showed that masks reduce transmission by 8-fold in schools. When masks are married with ventilation, as well as HEPA filters, that risk reduction goes up to about 30-fold. So yes, masks do work. Again, especially if they're fit well and they have the filters, so they have 2 or more layers to them.
Thank you. Let's go to the next question, and maybe this one I'll address to Dr. Katz. If you're dealing with a patient who has an immunocompromising chronic condition, do you think that there's a difference between patients who are have active immunocompromised disease versus somebody who may be in a remission but still taking immunosuppressive medications?
Yeah, it's a great question. So I think if you're immunosuppressed, you're at risk. I've actually had two patients I've taken care of this week on the floor with COVID that have, one is on chemotherapy, the other is an organ transplant, and even though they've been vaccinated. So we know those folks break through. And as we know now, at least for my patient with an organ transplant, they are now approved as of a couple of weeks ago for a booster shot. And those are the folks that are getting appropriately first in line for a booster shot. And it's encouraging that we have some options for them now. I think I saw in the question also that was embedded, if you've had an immune disease, but you've now recovered from that fully, so your immune system is fully intact. Again, I'm not an immunologist, so I'll take my best guess at that. I think that you're probably back to being fairly protected from an immune standpoint. However, depending on what that disease is and what your chronic condition with that disease is, we know just like any infection, the more chronic diseases you have, the more likely you are to succumb to any infection, in particular this one.
Yeah, and I would concur with that. I've actually had conversations with people who've had stem cell transplants in the past, primarily for leukemia, and individuals that are now between 3 and 5 years from their transplant are considered to be normal in terms of their immune system and not at any greater risk. Caitlin, would you agree with that, or do you have any other comments to add?
Yeah, absolutely. I do agree. And I think it's important to note that even if you get the third booster dose, unfortunately, it just doesn't work for everyone. I think among that didn't get it, the third booster dose only improved among 60% of those. And so we need immunocompromised, even if you get the third dose, to continue to just assume that you don't have protection, be vigilant, wear a mask, because we are still learning really quickly to figure out how to best protect those folks.
Thank you. So maybe I'll let you address this next question about the Delta variant. Do you think that there is a greater risk to young children, certainly those under 12, with the Delta variant versus what we saw previously earlier in this year in 2020?
Yeah, that's a really good question, and I get it all the time. Unfortunately, we don't know right now. So we have some preliminary data from Scotland and Canada showing that disease with Delta is more severe among adults. We do not know this yet among kids. And yes, our hospitals, our pediatric hospitals are full right now, but that's really because we think because of transmission. These kids are just getting exposed to it more right now. We just don't know about the disease. We are trying to figure it out as quickly as we can. And so that's really why it's important that schools put in public health mitigation measures to help protect the kids.
Thank you. So maybe, Scott, you could take a different approach to that same question, but from your perspective, are you seeing differences in hospitalized adults with the Delta variant versus what you saw in 2020 or earlier this year?
The only striking difference is the age of the patients. I think earlier this year when the vaccines first came out, if you watch the long lines in the mass vaccination sites, first of all, we rolled it out to the older patients and stuff, and they were all in line, but they were clamoring. And I think most of them got the message. And we know, Caitlin can help me, she's the epidemiologist, but I think that proportion of the population is far much more vaccinated, and it goes down as age goes down. So yeah, it's clearly shifted. In fact, I haven't seen, in the last 2 weeks, I've had 15 COVID patients. I don't think I've had a patient over 60. On my ward, on my service. They've all been in the 30, 40, 50 range. And then I'm just hearing the horror stories from my colleagues of the 22-year-olds on vents, in the ICU and younger. So that's really been the shift. I'm not seeing the severity change that much. I think some patients, we are only in the hospital for a couple of days. Other patients I have to send to the ICU. What also we have that's different than the first wave though, is we sort of understand this. We don't have that scared and that almost chaos because we had no idea what this is. So patients that we used to rush to the ICU, last year, we keep on the floors now because we know how to watch them. But the age is clearly shifting.
Yeah, well, thank goodness that you're better able and equipped to be able to manage these patients and keeping them out of the intensive care unit. Caitlin, do you have anything else to add regarding the Delta variant in adults?
No, I don't think so. Regarding severity, no, I don't.
Mm-hmm. All right. So maybe another question is, the push to get children back into school. And I know you mentioned this a little bit during your presentation, Caitlin, but talk a little bit about balancing the need to get children back into school and socializing and being active with activities versus keeping them safe and, importantly, keeping their families safe. I recently heard about a family where both adult parents were vaccinated and a 1-year-old child at a daycare contracted coronavirus and developed COVID, hospitalized, and both of the parents ended up with COVID-19 and hospitalized as well. So clearly the transmission was from the 1-year-old to the parents. So how do you see this, and how would you counsel people about balancing that, getting the children either into school or back into daycare?
Yeah, it's a hard decision and a really frustrating one. I am a parent of 2 little ones too. And so it's really important that kids are in school. The structured learning is incredibly important and then also on equity perspective, kids rely on schools for food, for safety, for mental health. There's so much, it's a multifactorial environment for the kids, and we need it back. But there's a big if, and that's if the schools implement public health measures. And we know that this can be done. Study after study after study in the past year has shown that, public masks, ventilation, social distancing, if possible, really work well in schools. And like you said, yes, we're concerned about kids. Thankfully, the disease is just not as severe among kids. But we also have to think about this at a population level. So we know that kids transmit the disease as effectively or even more effectively than adults. A new study came out in New England Journal of Medicine that's showing that 0 to 3-year-olds actually have a higher viral load and transmit even more than adolescents and adults. And so we're not going to end this pandemic unless we stop or try and stop transmission among kids. And so doing that in schools is really important. Now, for those that are under age 5, under kindergarten, this is a really great conversation to have with your pediatrician to weigh the risks with the benefits of keeping them in school. I personally took my 2 girls out of daycare. But that's because they're under 2 and they don't need that socialization that the older kids need as well. And so really is a hard decision, and we need to work together to end this pandemic.
Yeah, thank you. So
Len, can I add something to that?
Please.
What really scares me as an adult hospital physician is that October is scaring me. The kids are going to go back to school. They're going to all spread this around. Whether they get sick or not sick, we know that they're infectious. And all the unvaccinated patients are going to end up in the hospital. And I don't want to go back to doing rounds in a parking lot because that is not any fun.
Yeah, exactly. So the next question I'll address and then put it to both of you. For individuals who receive their 3rd vaccine, the booster dose, precautions really shouldn't change. They should still be wearing a mask and trying to, practice the physical distancing and all of the other precautions. But is there any other information about the third booster in terms of when you would expect to see that immune response be at its peak? So Caitlin, maybe you can take it first.
Yeah, so it's going to act, so the booster dose is the same, we think, is going to be the same exact vaccine that you got the first 2 rounds. And so we expect the same things. You're going to get symptoms, 50% of us are going to experience some symptoms the first 48 hours. It's just going to happen, but that means the vaccine is working. By 2 weeks after your 3rd dose, you will be at ultimate protection that you can be. And so you're right, maybe you can become a little more liberal with your activities, but everyone, even vaccinated, fully vaccinated, needs to wear a mask because they can still transmit the disease to unvaccinated pockets. And so I think I answered your question, but
exactly.
Yeah, okay.
Yeah, Scott, anything to add?
No, I just, this virus is killing people by just incredible. It killed my father last year. And so I'm really sensitive to this. I think you do everything possible to mitigate getting this and spreading it.
Yeah, I think one of the things that people don't recognize that Caitlin, you just mentioned, is that there's 2 purposes for the mask. One is protecting me and the other is protecting you. So, you will decrease the viral shedding from yourself to somebody else, and you'll decrease the opportunities that other people around you have to get infected. Even if you don't have symptoms, you could still be shedding that virus. So I think it's really important, masking.
Len, I use the driving a car analogy. You wear a seatbelt, which is a law in almost all of our states, if not all of them. That protects you. Not driving drunk protects you and the other people on the road. Right. Not wearing a mask is like driving drunk.
Yeah, great analogy. Do I have permission to use that one? That's good. So there's a question in here that I'll take on, which is there any research on vaccines and the effect on people with hemophilia or other bleeding disorders? And unfortunately, there isn't any specific data that's been generated in people with bleeding disorders. People with bleeding disorders were not identified to be a high-risk population, except in one case in West Virginia. There's no biological basis for people with bleeding disorders to be at a higher risk for either getting infected or having more severe disease. The challenge for people with bleeding disorders is, in Scott's realm, it's the management of those people once they get infected and they get sick. The management challenges are pretty substantial about giving anticoagulants to somebody who already has an underlying bleeding disorder. And we do have some recommendations on that were developed by an international group of experts on the management of COVID-19 coagulopathy in people with bleeding disorders. So those are available, and I think we can post those into the chat so that people will have that link. Another question is, if you have antibodies from having previous infection, do you get the same immunity as being vaccinated? So what's the situation for those who had an infection versus getting vaccinated? So let's go to maybe Caitlin, you can take it first.
Yeah, it's a really great question. Unfortunately, we call it natural immunity, just doesn't work as well as vaccines. Natural immunity is a lot more messy, and vaccine-induced immunity is very direct. It has the exact instructions your body needs to fight the virus. I will say, though, that this is very dependent on the severity of your natural infection. So, for example, Scott, who ended up in the ICU, will likely have a really great natural immunity response compared to someone that had mild or moderate disease. Unfortunately, though, we just don't know the patterns of people. Even those that end up in the ICU, only 80% of them have lasting natural immunity. And so that's why we're just telling everyone they need the vaccine, even if you've had natural immunity. the cool thing though is that, for example, with Scott and his 2 vaccines, he basically already had a booster shot. We're seeing in studies that his response is so much higher because of that than before. Now he'll likely get another booster shot, I hope, but it does help some, but it does help. And so, you know, that's why everyone needs to get their vaccine doses, the full amount, regardless of a previous infection.
Okay, Scott, anything to add?
No, it's just shot in your arm or 8 days on a ventilator. Why don't you get a shot in the arm? It's a lot easier way to get antibodies.
Yeah, definitely. So maybe we've got time for one more question. And that there's a specific question, Caitlin, about one of your slides where you showed the sort of the heat map for the country in terms of COVID. And there was the question was, what's going on in Nebraska? Is that a lack of reporting, or is it true that there are so few cases in Nebraska?
No, that's lack of reporting. The state of Nebraska stopped reporting in July in a systematic manner. So every map you should see will be grayed out. That's not because they have some immunity roll around Nebraska. It's just because they're not systematically reporting anymore, unfortunately.
Exactly. So do you anticipate that we're going to need a booster vaccine like influenza every year? Is this going to be, you know, the pattern for us into the future, that we'll need a COVID vaccine booster shot on a regular basis? Scott, what do you think?
Oh, I have no idea. We didn't know about this virus 21 months ago. That's way too early to ask that question. We're learning, you know, every day. So I think that's probably really important, because we hear people say, oh, well, you said I had to do this and now you're changing your mind, I have to do this, and it fluctuates. This is brand new. The science is evolving rapidly. I mean, this is COVID. I mean, I tell you, I had a hiatus about 4 or 5 weeks of not taking care of COVID patients. I'm right back into the thick of it now. I went in a refresher and read all our new guidance because I knew it had changed in the course of a couple of weeks. That's the way it is. So I think it's impossible to predict. I think one of the hopes is now that we're going to move to boosters, what will be really important is to follow the patients with boosters, the folks that volunteer to be in the research studies, so we can then follow their blood test and see how long that immunity wanes, or how long it stays. And that will help protect us, just like we're showing now that we're seeing that the immunity levels sort of drop at about 8 months. I participated in one of those trials after I got sick. Went in every 3 months and gave blood so we could try to figure that out. And so I think we'll know here in 6, 8, 10, 12 months what the booster does, and that will inform the decision.
Yeah, so I'm going to ask and answer the last question for us, which is any idea about what vaccine might be best to have if somebody has a bleeding disorder or is on a particular clotting medication like Hemophilia? And my answer to that is pretty simple. Whatever one is available to you is the one that you should get. There's no rhyme or reason why you should get one or another. There are guidelines for the administration of vaccines in general to people with bleeding disorders that have been tried and true for more than 2 decades. So receiving vaccines and these types of injections is safe to do. And we also know that they're extremely effective at preventing disease. So I think with that, we will thank our guest speakers, Dr. Katz and Dr. Jetlina, for excellent presentations and really thorough responses to the questions. And we'll try to get some answers to these additional questions. There's probably 50 or 60 more questions that came in, and we'll try to get answers to those and be able to post them on our website in our frequently asked questions section. So thank you and have a good evening and enjoy the rest of the conference.